Please go ahead.
Good afternoon, everyone. I'm Subodh. I'm the Dean of the Royal College of Psychiatrists, and a very warm welcome to you all. I think we need a warm welcome today. It's really wet and cold where I am, and I don't know where people are logging in from. Do feel free to put in the chat where you're logging in from. But a warm welcome to the second Dean's Grand Rounds. As you all have probably figured out, the Dean's Grand Rounds are slightly different to our traditional Grand Rounds in that we are really trying to narrow the gap between evidence and practice. And we have four key elements. And the first and foremost is the lived experience. And I think that really brings to life the gap between evidence and practice and the impact that it can have. The second element is the academic evidence. The third element, quite crucially, is that public health or population health lens to see what is the impact of that gap, not just on the individual concern, but also on the wider community. And the fourth element, quite crucially, is quality improvement. So in the spirit of quality improvement, I hope that all of you will try and pay attention to what is it that you can change in your own field of practice. So in the feedback, which I hope you all will take part in, try and at least give us some indication of what is it that you intend to change, or what is it that you are hoping to improve to narrow that gap between evidence and practice. So without further ado, I mean, I am very, very grateful to the old age psychiatry faculty and the chair, Krish, if you're here, please come up, and Paul Walker, the chair of the division, because a crucial part of our grand round is to have this co-hosting. So from the faculty that really is aware of the meaty issues in relation to practice, but also divisions of the college where we know who can bring in the ground level, community level, and the population health level connection. So thank you all. I hope that you all have a enjoyable time. Use the chat function to have a conversation. And with that, I'll pass you on to Krish and Paul.
Hello, everybody. A warm welcome from me as well. I'm Paul Walker. I'm a consultant psychiatrist up in County Durham, where it's also pretty miserable at the moment. And I'm chair of the Northern and Yorkshire Division. So this is a joint effort between the division and the faculty. And I'll say now that I want to give my personal thanks to Krish, who has done by far the majority of work on arranging the fantastic programme that we have today. And I understand we've got numbers just below 1,200 have registered for this, so that's fantastic. So it's my particular pleasure to introduce our first speaker, Mrs. Pam Banks, who will be talking about the very personal journey that she and her husband have had, both to a diagnosis of dementia, but also, more importantly, after that, living with dementia and what makes a difference. It's an extremely personal thing to do, and I think in many ways this is the most important speaker session that we have, and therefore we've given it pride of place at the very start of our webinar. So I want to give my sincere thanks to Mr. and Mrs. Banks. Thank you.
Please go ahead.
It hasn't.
Pam, we can hear you now, and your slides are on screen now.
Okay. Diagnosis shouldn't be a postcode lottery. I think the best way for me to share our journey is to start in my husband's own words from when he was able to tell his story himself. My story starts when we lived in rural Norfolk for 4 years from 2010. 2012 to 2014, my wife particularly noticed several things in my day-to-day living which didn't seem normal. I was forgetting things, doing some bizarre things in my day-to-day living, and at odd times, my driving was erratic and my judgment questionable. I had trouble sequencing and prioritising my needs. I got easily frustrated and sometimes angry. I found some day-to-day tasks more difficult than before. Not that I admitted to any of this. There was nothing wrong with me at all. I did agree, grudgingly, to go see our GP to prove to my wife I was right and she was wrong. The GP we had, while an excellent practice for other things, listened to our concerns, but put it down to lack of sleep and thyroid problems. Not once did he support my wife's worries about dementia, or even worse, that after having bladder cancer, had it spread to my brain. He certainly never investigated for dementia. After taking blood tests, he prescribed levothyroxine, which I still take, so our GP was partly right in his diagnosis. This supported my denial, and though the problems in my day-to-day living were still occurring and getting slightly worse, we had to accept the GP's findings at that time. I also had emerging cataracts, which seemed to explain my wife's concerns over my driving. I had both eyes operated on, but though I still had all the trouble afterwards driving, I knew from what our GP had said, there was no reason for me not to drive. We needed a car in rural Norfolk. As time went on, I had a few excursions with the ditches on the very narrow and unlit roads. One time I forgot to turn left at the end of the drive, so slid into the ditch opposite our house. This ended with the police and fire brigade being called to get us out of the car. The car needed extensive repairs. Luckily, we were all okay. We had my wife's elderly mum in the car also. Still, I kept driving. The final straw was months later when we were coming out of Norwich on unfamiliar roads and I had to concentrate more. I failed to see a zebra crossing and almost knocked a lady down with a double push chair. I drove home, put the keys down and said, that's it. I obviously aren't safe driving. It really scared us. This was the final realization and acceptance by me that there was something very wrong. We sold the car. We are lucky I was able to make that decision myself, as to a lot of patients, it causes untold stress. This coincided with us moving to Middlesbrough in August of 2014. We luckily didn't need a car as much here. In the autumn of that year, I was watching a rugby match and to my horror, realised I could no longer remember the rules of a game I had loved since I was a child. This was the first time I was prepared to admit there was something wrong with me. My GP here listened to us and on our first visit took blood tests and referred us to the memory clinic. We got an appointment really quickly and by January 2015, we had been to James Cook for the brain scan. At the next memory clinic appointment, the clinician on giving us the results said, I know this isn't what you want to hear, but for us, it was a big relief to at last have an explanation. I was prescribed on Episil, and after several visits during the month's trial, I was prescribed the full dose. This seems to have suited me. I have had no side effects, and it has slowed the progression down. My husband is no longer able to articulate his journey himself. We both would say getting a diagnosis is not the end, more the beginning of living with dementia. We would say medication is only part of the journey. lifestyle and opportunities help as much, if not more. My husband has been lucky enough to have done 2 CST and latterly an MCST course. The first was a trial for 40 weeks and a couple of years before the second 2 courses. We are lucky enough to have a dementia and wellbeing hub here based at Woodside Memory Clinic. The hub is an important resource in the community, enables safe transfer from CMHT. It is a valuable resource. We have lots of fun, a listening ear, and loads of peer support and plenty of cups of tea and coffee. My husband's favourite phrase is, "I love the hub." And as a wife and carer, I couldn't manage without it. My husband's first words every day are always, "Are we going to the hub today?" Unfortunately, I think COVID years have had an impact on the diagnosis service, even here. As I'm talking to other new caregivers beginning the journey, it appears that waiting time is longer, causing stress. And that's worrying, as we all know, the sooner you get a diagnosis, the sooner help can be given. My husband is living as well as he can on his journey. I do wonder, though, if we had had the diagnosis earlier, would he be even better?
Thank you so much, Pam. That was just absolutely fantastic. And I just want to reiterate my thanks to you, and you've got thanks in the chat as well. It really sets the scene for why today is so important and why we've had so many people registering. So thanks ever so much. And I'm going to pass on now to my colleague, Krish.
Thank you, Paul. I would again echo both the audience and our panel's gratitude. Thank you, Pam, Mr. and Mrs. Banks. It's quite moving, and I think the last words, as you said, could Mr. Banks would have done better had he been diagnosed earlier. That's quite a moving tribute. Thank you so much for that. So thank you, everyone. Thank you, Subodh, for your kind words, and thanks, Paul, for your support in organizing this for the Northern and Yorkshire Division with our faculty. So next slide, please. Yeah, I just want to draw your attention to a few things. I'm not sure whether you have read some of these reports. I'll try to put some of the links in a chat. So there was a paper by our Alzheimer's Society colleagues on left to cope alone. And then the National Audit on Dementia, the summary report came August of this year. And there is another kind of a consensus document that was facilitated by Leeds Beckett University, talking about taking the memory assessment service into the future. And then that goes on to nicely to talk about, are we ready to deliver disease-modifying treatment? So these are some light reading for the delegates if they want to look at that. Next slide, please. I'm sure as an old psychiatrist and people, working with memory services, none of these will be new to you. So just to think about key priorities for us are, I think as Pam rightly started the conversation today, diagnosing early so that we also are diagnosing accurately and consistently is really, really important. And let's not forget the waiting or a backlog that has happened over the past 2 years, which I'm sure across the country, we are all trying to manage. I would not kind of, can't talk about dementia without embedding research in our clinical practice. I think it is really, really important that every clinician is actively involved in research. Just to signpost, Joint Dementia Research in UK is a key kind of a vehicle that you may be able to all signpost our patients and carers to get into research. And then addressing inequalities in accessing diagnosis and treatment. Pam nicely mentioned diagnosis shouldn't be a postcode lottery, making sure that rural and remote areas, as well as urban areas and tertiary centers, are able to cater for every population, including minorities, people who don't speak English, people have different cultures, that they all are included in making sure that they all have access to diagnosis. And we will be talking about access to high quality data. I think data is really important in looking at where we are at, but there are some inconsistencies. Just to signpost some of these audit data like National Audit of Dementia, as well as our colleagues will talk about how we can access some of the national data like fingertip data. And then finally, innovation. That's COVID definitely accelerated some of the innovation, including remote consultation, remote diagnostic work, but also we just need to be ready for new treatments if and when that are available. Next slide, please. So what I would like to do today for the grand rounds is we'll start with what does the data tell us, and then how that can be related to our local data. And then we'll start explaining about our local experience, what we are doing. So without further ado, I would like to introduce Catherine Parker, one of our public health consultants in the Northeast, who is going to give us a quick overview on what does data that can tell us about dementia and memory services. Welcome, Catherine.
Thanks very much, Krish. So I'm just going to take a couple of minutes to go through how data can assist us in working through some of those priorities that Krish has outlined. So if I can have the next slide, please. So population health management is an approach which provides some useful tools to help us maximise the use of data, really to improve health outcomes and reduce that unwarranted variation that we see between different groups. And we can do this by segmenting our populations, so really drilling down to see what the population health need looks like for specific groups. Through risk stratification, so then examining how risk might present differently over time in those different groups. So for example, there might be particular groups that are at heightened risk of late diagnosis, or groups that are at significant risk of decline between referral and diagnosis. So that risk stratification approach really helps us to understand that for different populations. And then we can much better model our interventions to address those specific needs in subsets of the population. So can I have the next slide, please? So why this might be helpful in terms of dementia diagnosis? Well, the NHS is a big and complicated machine, and so we like standardised processes. But what we know is that the need for healthcare and support varies significantly in our communities. So we know that multimorbidity is the norm, so people may be grappling with several long-term conditions across different bits of the system, and it really helps us to understand what that looks like for people when we delve into the data. We also know that social, cultural and demographic factors play a significant role in people's ability to interact with services, how they experience services and the outcomes that they achieve from them. So it might be, for example, that issues like health literacy, poverty or cultural norms can all impact on people's ability to benefit from that standardised offer. So looking in more detail at the data really helps us to provide a much more holistic picture of that health need so we can better respond. If I can have the next slide, please. So how might the data really help us in general terms? It helps us to benchmark, so we can support understanding about how we're doing in comparison to other areas. It's great to see that we've got an international audience today, so comparing ourselves to other parts of the world and to other geographical areas in the UK and to other GP practices at a place level. It helps us to project and predict to support planning, so we know what's coming, and that might be in terms of social changes, demographic changes in terms of the ageing population, but also, as we're seeing now, significant economic changes and how they might impact on people's broader health and well-being. It also can help us understand gaps. So having a look at who we're not seeing, who isn't presenting in our data, how does our patient population differ from the wider population? Who might we be seeing late, and other differing presentations? So are some groups more likely to present in crisis, or other groups more likely to present very early on? And it also helps us to understand who we are failing. So Microsoft call this the triple fail events, where people experience low quality, high cost and poor experience outcomes. What it might not tell us is why, and that's why it's so important that we started with Mr. and Mrs. Banks's story there, because we must always triangulate data with that lived experience, with what people are telling us about services locally and what their experience of those is. So we must always do that triangulation with people's lived experience. But of course, all of this relies on the need for high data quality. And we know that we are currently experiencing some significant challenges with data. And Emma is going to talk us through a little bit about what that landscape looks like for dementia. So I'm going to hand over to Emma now, I think, to take us through that.
Afternoon, everybody. I'd like to show you the range and the variety of data that we have available to us in dementia services, to look at the positives, the challenges, and how to make the best of that data. We work to the well pathway for dementia, and that includes preventing well, diagnosing well, supporting well, and sadly, when the time comes, dying well. We work in an increasingly flexible multi-agency landscape where services can be delivered by a wide range of providers, and it was great to see that acknowledged in the National Audit of Dementia this time. So there's many data sets available, and now it's really easy to access that data, especially through the NHS Futures platform. Going forward, that platform will be able to have fantastic dementia dashboards. They're not live at the moment, but there's a huge body of data in this dashboard. One of the most frequently used reports that we use is the fingertips data. And this shows us the expected diagnostic rate for our areas for people over 65 and for those under 65, and it shows us our actual diagnostic rate as well. And while it's an important piece of data in terms of allowing benchmarking and comparing across regions and being able to share best practice, the most important part of this data is to be able to identify that gap. We need to find those people, the people who we would have expected to have dementia, but we haven't diagnosed yet, because we need to get that help early, target support, and get services to them. We also regularly use the data set for antipsychotic medication prescribing for those with dementia. We know that antipsychotic medication, whilst hugely helpful, can pose a risk to people with dementia. So we strive to keep that prescribing to a minimum. And concern was raised during the pandemic that prescribing rates had increased significantly nationally from 7% to 11%. So as a trust, our figures actually fall below those national figures, but we need to be really, really careful in terms of the monitoring of that data, because it uses the diagnostic dementia registers. And we do have an issue with getting those diagnoses made in a timely way. There is a concern that there are people with dementia who are undiagnosed who might be being prescribed medication. So as a safeguard, we tend to cross-reference that data with trust held data, and we liaise with community pharmacy colleagues as well, just to double check that data. The Futures platform allows you to look at a multiple set of data, and there's far too many to list at the moment. But what I would say is it includes mental health data set information, CQC information, health survey for England, ONS, global burden of health. So it's incredible to be able to see all that data in the same place. So data is really helpful for benchmarking, for research, for developing services and targeting support, but there's a need to understand that data, to understand where it's been extracted from, and to understand its limitations. And there will always be a need to sense check that data, to compare it, to triangulate in order to make sense of that data and to get best use. Next slide, please. So one key way to check the metrics and the data is to check against national audits, local audits, research and reports. And we're very, very lucky that we actually have a great number of resources in dementia care. So the National Audit of Dementia took place this year, and it highlighted delays caused by the pandemic. And one of the key findings was that the time from referral to diagnosis nationally had increased from 13 to 17 weeks. It also highlighted that many services had stepped down work during the pandemic, and many staff had been redeployed. And one of the key recommendations was that we use quality improvement methodology to robustly measure and to improve the times taken. So as a trust, we are working with NHS Digital, with the National Dementia Dashboard, but we're also creating a digital dementia dashboard within our trust. And that will look at the patient's journey from referral to assessment, to scan, to diagnosis, to medication time, to those supportive interventions. And although we didn't stand down services during the pandemic, we have had delays, and the multi-agency delays that prevents sort of referral to diagnosis time being within that 11-week target time. So we're looking at all those potential bottlenecks and looking at all the creative solutions that we can put in place. There's also research to show that young onset dementia times are also an issue. So young onset dementia patients make up a good 7.5% of people with dementia. And whilst on average, they say from recognising the problem to actually getting diagnosis might be 2.2 years for older adults, that's 4.4 years for people with younger onset dementia. So as a trust, we complete a lot of horizon scanning across many subject areas and many research projects. And this enables us and has enabled us to complete a forecasting tool. So that tool allows us to understand our current and our future demand for services. And that works highlighted a potential 50% increase in workload for people, older people. And what we found is that 27% of that increase in need would come to us as a secondary mental health service. The other key report that I've put on that slide is the Alzheimer's Society Left a Corpus Loan report. And this highlighted the increased number of patients who felt that their condition had decreased in the previous 12 months, the increase in number of people who required A&E support, and the number of carers that felt stressed and burnt out. And this certainly links to our local data, which shows an increase in number of contacts per patient and an increased number of re-referrals into service. We are really fortunate that we've got access to so many data sets to research and reports. But I think the challenge that we face really is the time to sense check that data, the time to triangulate that data, the time to apply that data, and to ensure that we value all data that we have. And especially for me is the narrative and the rich information that comes from our patients and carers. Thank you.
Thanks, Emma. I know, I'm sorry, I saw some chat about the graphs are too tiny. I think it's partly apologies to me. I've said they need to limit their slides because of the time. I'll try to make sure that we'll get some of the links put on the chat. So having seen what data can do with regard to bringing it to our local services, now I'm just going to request a couple of our colleagues to talk about what are their local initiatives on how they have been tackling memory services. To start with, I'm going to introduce Dr. Venkat Muthukrishnan and Dr. Ollie Bekarma, who have been doing some great work in the last couple of years. Over to you, Venkat and Ollie.
Thank you very much for the introduction, Dr. Krishnan. I will invite my colleague, Dr. Ollie Bekarma, to sort of talk about the work, the fantastic work that he and his colleagues have started, and then I will follow on from that. Dr. Bekarma.
Great, thank you, Venkat. So next slide, please. So just to provide a bit of context, really. So the pandemic was very challenging in terms of cognitive assessments, and particularly the cognitive screening element of that. Pre-pandemic, we used the Addenbrooks. It was embedded in our pathway. We had a comprehensive package of training for staff, audits, and remote assessments weren't used. In the context of the pandemic, we had to think quickly about how could we provide some form of objective cognitive assessment to inform that differential diagnosis process. We explored different options, but we settled on the Addenbrooks remote version. What we found with that was that there was a mixed uptake, and that didn't necessarily reflect the training. It was more around issues around digital poverty, so access to technology to do video-based assessments or kind of broadband within more rural areas. So it helped us to kind of work through some of the referrals coming through for dementia assessments, but not all of them. And I guess where we're at now in terms of the current picture is that it feels like for the majority of services, we've reverted back to what we were doing pre-pandemic. So face-to-face assessments and face-to-face cognitive assessments. That said, there are still some pockets of what we might call hybrid assessments, whereby someone might have a telephone or video-based interview. So asking them about their difficulties, collateral information might be gathered in the same way. And then there might be a briefer face-to-face interaction to do a cognitive screening test. Next slide, please. One of the other areas we've been working on is around training for staff. And the reason we've done this is because we've identified quite a lot of variance in terms of adherence to the dementia pathway. And that has come across at different points. So particularly around the quality of the initial assessments that we do, but also, I guess, further along that process in terms of the quality of diagnostic appointments, and also that long wait for diagnostics, which has been mentioned before. And from doing some scanning and talking to people who work to our dementia pathway, what we identified was that the issue was more about staff training, confidence, competence in some areas, rather than the pathway itself. It's a very well-established dementia pathway. So in seeking solutions, we looked at some of the existing training packages available in terms of kind of dementia-based teaching, but what we actually identified was that we need some bespoke training for staff working in the area. So we've developed two lots of bite-sized training. So the first one is around how to complete a high quality or gold standard initial assessment within the context of a dementia pathway. So that covers everything from clinical interview to getting collateral information, to doing a cognitive screening tool, but also things about how to write up a mental state examination and to communicate this information within the context of something like a multidisciplinary meeting. The second lot of training that we've developed is around how to facilitate a high quality dementia diagnostic appointment, or what you might call a feedback appointment. So even if a diagnosis was not reached, and again, what we found is from speaking to service users, carers, staff, that there's inconsistency in terms of those dementia feedback appointments. And so the idea with this is that we're trying to drive up the quality, provide staff with a set of standards or guidance for how to facilitate those meetings. But also we've been thinking about introducing new staff into that process of giving a diagnosis. So for example, where the diagnosis may be something like a mild cognitive impairment or Alzheimer's, and there aren't any identified additional complications, then it might be appropriate for a psychologist or a nurse or another senior clinician to do that diagnostic meeting. Okay, next slide, please.
Thank you, Dr. Bekarma. So what we are doing locally in our trust is focus on the first three things as the three key targets. But I will come on, before going on to that, I'll mention also about young onset dementia, because what we have realized, as is often the case when you go through a massive crisis like a pandemic, people with sort of relatively rarer conditions, and young onset dementia is one of them, tend to get affected more. So we have also kind of having a special focus on that. And we are doing two things. One is locally within the trust, we are talking to all the relevant clinicians across the two specialities of working age and older adults to streamline that process. But simultaneously, we are also talking to the two ICSs that the trust comes under to kind of see how we can coordinate, because young onset dementia particularly is a lot about integrating with the relevant stakeholders across the board. Now, in terms of the first 3 points, which is the current focus that we are having, doing. In terms of referral to assessment and referral to treatment, we wanted to really kind of focus on that and tighten up and kind of make it as quicker and as a flow as possible. And you heard from Dr. Bekarma the fantastic work that he and his colleagues have been doing on the initial assessment. We are also exploring remote working, which we did do a fair amount during the pandemic, but we also incorporated MDT working into the pathway where appropriate, other non-medical colleagues can, with the help of the medic, make the necessary diagnosis as a means of, again, reducing the waiting list. And we were also in the process of arranging a QI event to just specifically focus on this, as well as visiting various teams to understand what have been the enablers and barriers for all the services in the last 2 years and as they come out of the pandemic. Now, in terms of delivering dementia diagnosis, again, for building on the work that my colleague is doing in terms of delivering dementia diagnosis and incorporating all the sentiments that Mrs. Banks so very validly described at the beginning of this webinar into that sort of training to kind of, again, make it very, very person-centered is the second focus that we are doing. And simultaneously during that process, we'll also be looking at, again, kind of sharpening and improving the consistency of diagnosis. Because we are a very, very large organization with multiple teams and services. So we want to kind of, again, bring an element of consistency and efficiency, improve upon the consistency and efficiencies that we've got. And in terms of the third target of measuring and monitoring outcomes, that's again very, very important, not just as a means to understand where the issues are, but also an important means to celebrate the hard work and achievements of various teams. So just to give an example, in Teesside, they did fantastic work during COVID, using very innovative methods, working with the volunteers to reach out to inaccessible communities to continue to deliver memory services and diagnosis and treatments. So it's just sort of building on that would be the kind of key things that we will be focusing on. The next slide, please. So going forward, we are already in the process of developing a digital dashboard that, again, makes it easier for us as an organization to have a broad understanding of all the services where they are in terms of various touch points. And that will, again, enable us to sort of share and spread the good work that's been carried out in individual teams, and so that there's an overall improvement in that position. The digital priorities is very, very important, and that's been mentioned in national documents. So we are looking at exploring a digital front door for memory services as well as for other services going forward. It is important to bear in mind that whenever you talk about digital things, digital exclusion and digital poverty and health inequalities actually come into play. But sort of recently happened to hear from the Director of Health Inequalities at NHS England, Dr. Bola Alogby, and she was mentioning how digital can be actually an enabler, not only identifying health inequalities, but addressing health inequalities, and gave some fantastic examples. So I think it is important that we kind of look into that as an option. We are also working with primary care. We have a very strong relationship with primary care across the organization, and even before the pandemic, we were working very closely with primary care in terms of streamlining the dementia process, and that took actually more speed during the pandemic, and we are building on that going forward, as well as working with relevant voluntary care and social enterprises, particularly like Dementia Friendly, which is a very, very effective voluntary organization in our trust in terms of delivering and developing things like cognitive stimulation therapy, because that's something that we would want to have across the whole organization, and then build on the post-diagnostic support, because again, going back to the sort of very, very powerful presentation by Mrs. Banks at the beginning, medications are only a part of the solution, and we need to kind of look at the post-diagnostic support and how we can build more into that. So those are the things that we'll be focusing on in the future. Thank you very much.
Thank you, Venkat and Ollie. Now, I would like to introduce Dr. Charlotte Allan, who is a colleague from Cumbria, Northumberland, Tyne and Wear NHS Trust, to give her local initiative and what has been happening across the pond, across the river from us. Welcome, Charlotte.
Thanks, Krish. Next slide, please. That's me. Thank you. Next slide. So I work at Newcastle Memory Assessment and Management Service, and we're a service primarily to diagnose dementia, but we do accept referrals, usually from GPs, to assess patients of all ages who have got memory changes. And our primary focus is the assessment and diagnosis, and then initial management of people who've got dementia. And we offer some post-diagnostic advice and support, and then a medication review. We work in a very multidisciplinary way. So we've got a team of doctors, nurses, support workers, psychologists, and OTs. And our usual pathway is that patients are referred. They usually have a nurse assessment. They're discussed in our multidisciplinary team meeting. We then arrange further investigations, neuroimaging or other investigations. And then when those results come back, the patient is discussed again in our MDT meeting, and then they proceed to a diagnostic appointment. And then we offer follow-up bespoke to that individual. Next slide, please. So we have a lot of resources at our fingertips. I think our staff are the main resource, but we make very good use of structural and functional imaging. We obviously think about bloods. We've got access to ECGs in our clinic, and some basic physical monitoring as well. Next slide, please. So I'm going to talk about sort of three elements. The first is waitlist strategies. So before the pandemic, we used to have about 80 to 90 referrals per month, occasionally 100 referrals per month. And now regularly we're getting over 120 referrals per month. So we've had a significant increase in demand. And one of the things that we are doing is meeting regularly as a team to think about what is our strategy to manage this demand and to keep offering a good service to patients. The first sort of item on our agenda is that we need to articulate the need for more resources. If the demand continues to rise in this way, it's going to be very difficult to meet that demand unless we have more doctors and nurses and admin staff, particularly, to try and help us with that. But we've been looking at our service model to see what can we do locally to try and make things better more quickly. One thing we've looked at is whether we can fast track patients who have got low complexity. So if on the referral, it looks like the patient has got clear evidence of cognitive and functional decline, if they've already got a CT scan available, we're booking them straight in for review with a doctor, and they'll have a slightly extended appointment, but they can have a one-stop shop where they have assessment and diagnosis on one day. And that will save a more lengthy nurse assessment, it will save the MDT discussions, and it doesn't add very much time to the usual time with a doctor. So that's one area. Another area is to diversify the skill mix that we're using. So previously, all our diagnostic appointments were performed by doctors. But then when we were short of doctors, we then ended up with quite a wait to deliver a diagnostic appointment. So now in our MDT meeting, we make a provisional diagnosis, and then we do have access to other clinical staff who we have trained to be able to deliver a diagnosis. We have a non-medical prescriber who is a band 7 nurse who can give a diagnosis where it's Alzheimer's disease or a mixed Alzheimer's and vascular dementia. And we have an experienced consultant psychologist, and she can give a diagnosis where medication isn't indicated. So where it's a mild cognitive impairment or a vascular dementia. And that has really helped the flow through our pathways, having that extra clinical input at the diagnostic stage. Another element in our strategy is to review the documentation that we use. So the documentation is often perceived as being very lengthy and needing almost as much time to document as it does to actually see the patient. So what we have done as a team is to review what is the essential clinically relevant information that we need to document, and really trying to slim down what we require of staff to do on a routine basis. We're also making better use of digital tools such as Big Hand, which is an electronic dictation system, and a Modal, which is a voice recognition system. And again, it just helps to speed patients up. Sorry, speed up the process of documenting patient information. Next slide, please. So amongst all this, in terms of trying to speed up to be more efficient, we're always trying to balance quality versus quantity. So although we're trying to be more efficient, we still want to innovate. So we're developing better pathways to look after people who've got mild cognitive impairments through our brain health clinic model. We're trying to build relationships with GPs and with geriatricians. We're doing these service developments, so upskilling some of our staff to deliver diagnostic information. We also are very cognizant about sustaining staff. Our staff are working under tremendous pressure, and we need to look after them and make sure they can continue to work well and enjoy their work. So we focus very much on staff wellbeing, and we continue to offer post-diagnostic support groups that our staff run, obviously partly to improve the care that we provide for patients, but also because staff really enjoy running these groups. And although it takes them away from doing assessment appointments, it adds a bit of variety to their week, and it really helps to sustain them in the long term. Next slide, please. So the second thing I'll talk about is neuroimaging. The NICE guideline, so NG 97, is very clear that we should offer structural imaging to exclude reversible causes of cognitive decline and to help with subtyping the diagnostic. So we offer CT scans or MRI scans for the majority of our patients, and we also have access to PET and to SPECT. And we work very much within the NICE guidelines, making good use of these imaging tools. Next slide, please. There are some difficulties with this. So for some people I know have got problems with availability. Sometimes we struggle with reporting time. There's the issue of cost. Sometimes patients don't wish to have a scan, particularly say an MRI scan. If they're claustrophobic, they might prefer to have a CT scan, and we obviously adapt what we request depending on patient preference. We have had some solutions to this. So all doctors in the clinic now have access to view images on PACS, and that means that we can just be more accurate in the way that we're using the imaging biomarkers. We're upskilling psychiatrists to be able to look at those images with more confidence. We're trying to build collaborations with radiology, and we do that by trying to tell them what information we need on scan reports and trying to start some joint MDT meetings. I wonder also whether we need to start looking at using the patient voice to aid commissioning and to helping us to fund the imaging costs. And I do wonder as well whether we need to think about selective use of imaging. So where it is very clear that there is a dementia diagnosis, and perhaps say when somebody is very advanced in their symptoms, we might need to say a scan isn't necessary, it's not going to change our clinical management, we're very confident what the diagnosis is, and that might save time for the patients. It might allow them to get their diagnosis more quickly. So I think we do need to think about that sometimes, but doing that judiciously, being mindful of the recommendations from NICE. Next slide, please. The third element I'm going to talk about is post-diagnostic support, and I think this is really important. In Memory Clinic, we just really touch on post-diagnostic support. We provide initial management, and we're not able to follow patients up throughout the whole of their dementia journey. And I think that is a sadness to many clinicians in secondary care, but I do think that there are many organisations in the community who can offer this facility really well if we can work with them and if we collaborate with them. So the initial interventions we offer are about medication, starting it, titrating it, and maybe adding in a second agent. We offer groups, so we have an education group, we have a carer support group, cognitive stimulation therapy, and we have a memory group looking at memory strategies. We have OTs, so occupational therapists, who can look at very individualised strategies for patients. And we have a psychologist who, again, can provide some individual bespoke work for patients, so particularly those who are struggling to accept their diagnosis. But beyond that, our main role is in signposting. It's working with primary care, making sure there is somebody named who can actually follow up that patient. And it's collaborating with other organisations such as the Alzheimer's Society or Age UK. Next slide, please. One of the ways that we're helping to improve post-diagnostic care is by joining the collaborative Newcastle Dementia Partnership, and we're very much involved with the dementia strategy. This is a strategy that is collaborative across the whole of Newcastle. It's got very good representation from the NHS, from social services, from the third sector, who all want to make dementia care better. And we are looking at prevention, at diagnosis, information provision, living well, and at end-of-life care. And I think this will be really helpful in trying to guide some of the collaborations that we're trying to build from the perspective of secondary care. Next slide, please. So this is my last slide, and it's just to give you a brief overview. I think as a memory service, we've got some very good strengths. We've got evidence-based interventions, an MDT approach. We can provide holistic and patient-centered care. And we do have an infrastructure that can manage a large number of referrals. But the weaknesses, currently it's about the cost of neuroimaging and the wait for it, the wait for access to assessment as well, given our rising demand. We don't have any structures for CSF biomarker analysis. We've got a limited reach with cognitive stimulation therapy. We just can't offer it to enough people as we would like. And I think post-diagnostic care also needs improving. So the rising demand is an ongoing threat. The increased complexity of patients that we see makes it difficult for us to provide an efficient service sometimes. And we've got staffing shortages and administrative demands, as everybody has. But I think despite this, we're really optimistic as a service. We've got very good research collaborations. We're building on the brain health clinic networks, and we are trying to adjust our models to support staff and to build on the really strong team we've got to continue offering a good service to patients. Thank you very much.
Thank you, Charlotte. Next slide, please. Yeah, again, I'm just going to repeat what we started to discuss. Again, we can see various ways local services are addressing with regard to diagnosing early, diagnosing consistently, and also addressing inequalities, as well as using some of the digital innovations. I think there's lots of activities going on, and I just want to quickly mention a few things before we go on to discussion. Next slide, please. Again, there were some comments and questions on with the staffing shortage, you know, how are we with regard to delivering even the existing memory services. So this was a paper we did with ARUK. Bob Barber and colleagues did it last year. And then next slide, please. The key points are about we need to focus, I can already say, you know, initially focusing on our existing workforce, producing continuous professional development. Again, there's a very clear need for that. And then there were some questions and comments on use of non-medic, nurse practitioners and non-medics to deliver diagnosis. And there was also a question about, you know, how robustly you will be able to do that. I think what we hear from patients and carers are about as long as they're getting a timely, adequately kind of a robust and accurate diagnosis, they are not really, you know, worried about what the professional background is. That is really important. That's what our patient want. They want quick, accurate diagnosis, and then engaging with leadership on, you know, all the sectors on what changes we need, and then ensuring that some of these, you know, our readiness to new treatment or disease modifying treatment is included in our curricula. These are the key points that was discussed. The paper is there for you to read about. So next slide, please. Next one. Next slide, please. Yeah, I just wanted to, just to give you a quick kind of a view of this is what we use in the trust I work in with regard to a dementia care pathway. But you can already see there are, you know, bottlenecks, waiting for initial assessment, waiting for diagnosis. Then there is a question Ali addressed about accuracy and also quality and consistent access to post-diagnostic support, which can be variable. Next one. And again, as somebody mentioned, surprised about PACS access, and there were few questions on, Marissa, I agree with you about, I think all psychiatrists should learn to read structural imaging. That will be good. However, only 38% of the services at the National Audit of Dementia said they could directly view the brain scan, which is, really scandalous. And we do every service leadership plead to all of you that we should be supporting and working on how we can get all of us to have access to PACS trainings, PACS, image access. That's really important. So I'm just going to bring our panel, and then I'm just going to put some quality improvement questions. Next slide, please. So I know there are lots of things we can talk about, but I thought about timely, accurate diagnosis, and then access to neuroimaging. I think Carol mentioned about good quality reporting. Few people have mentioned about, having a neuroradiology meeting, but seamless access is really a key question. I had one of my patients, a 91-year-old person, partially blind. He had a scan for a fall, but when we asked for a re-reporting of the scan with a view to looking at the medial temporal lobe, I was told that's not part of the service level agreement, and they wanted me to re-refer him for another scan. Luckily, I was able to get the scan images through patient request, and clearly there was a hippocampal atrophy. We were able to give a diagnosis, but I would have wasted his time and the radiology unnecessarily, getting him to have another scan. So, and then let's not forget about the timely post-diagnostic support. So can we have panel, Catherine, everyone? Thank you. I suppose there were a few questions. I thought I'll see anyone would want to touch upon. So there were some individual case examples. I think we'll try to reply through comment because it's tricky to give an individual advice on a case. And there was a question by, has COVID had an effect on cognition? Would anyone want to answer that?
I suppose, I think it's fair to say that it probably would have had an impact, but in terms of, certainly from a sort of a social isolation and the sort of lack of stimulation point of view, but in terms of directly the sort of neuropsychiatric effects, we do know that COVID does cause cognitive impairment. Whether it is sustained or not is, I think only time will tell, isn't it? We would have seen definitely cases where there is an impact, but we need more data to sort of be very more conclusive about that.
Yeah, thank you. And then there was a question on, again, this will be probably there's a lot of chat going on about non-medics delivering diagnosis. So it will be useful to get some views. I think Vivek has put something, but anybody got any views? Charlotte? Sorry, I'm not putting you in the spot.
Sorry, could you just repeat that? I've just been having trouble.
I'm just talking about non-medics delivering diagnosis. There are some concerns. Again, Neha has mentioned, I think we should do an audit on, how accurately we are able to get non-medics, nurses delivering diagnosis. Yeah.
When we introduced it as a model, we did a very sort of clear service evaluation to look at that and looking at the quality and the content of those appointments, and then looking at patient and carer satisfaction. And we found that they were equivalent. So there was very little difference between the non-medical prescriber and the doctor. They were seeing different groups. The doctors were generally seeing more complex patients, and the non-medical prescribers were seeing people where the diagnosis was very clear. And there were some areas that I think the NMPs didn't talk frequently about, like research, but then we also see the doctors need to improve in terms of talking about that as well. So we were happy to then continue that with good supervision for our NMPs.
Thank you, Charlotte. And then again, Amanda mentioned about, what's the impact of, we've got medical staff shortage, staffing shortage. How does it impact on our diagnostic pathway? I suppose the answer is universal. It is impacting already, isn't it, in every service, I suppose. And the other point was, there's a lot of things on PACS. I think it will be easy that you could flick the switch and get PACS, but I'm afraid I've been fighting within our own local services for 4+ years. I thought it was just a flick of a switch, but it is not. So definitely one quality improvement we could all take a pledge on. I would like that 38% to go to 88 or 98 at some point, within a year. I do think that it is really important, especially when there is a delay in getting this diagnosis. So it is really important. Any other things people have looked at? I know I'm trying to spot comments and questions. Panel members, have you seen any questions? There was
a really interesting question about, can we really prevent well? And I think that's a really interesting question. I think there are so many factors that we can do, and I think sometimes the more upstream solutions seem to have the best effect. I know it's difficult to put the resources in there when we're facing such a lot of difficulties currently, but they don't have the better returns, really.
That's really important. And then Simon just popped a question saying that if psychiatrists are not actively involved, how good we are at picking at the less common dementia subtypes. I think, again, it goes back to the robustness of support and supervision. Again, like everywhere, you're not going to get like a band 6 qualified yesterday to start giving dementia diagnosis. It is about somebody working with you in memory clinic and providing adequate support, supervision, and training in developing, but also on the contrary, it could be like a first year out of CCT, somebody, again, I'm not here to, get at any health care professional. It is about teamwork. And my counterpart, the American Geriatric Psychiatry President, Rajesh Thampi, mentioned in the last faculty conference saying that you don't need a department, you need a country to tackle dementia. So considering Amanda's point about you've got a number of staffing issues, it is about how as a team we could work together. I think that's how I see it. Any other point on anybody looked at?
I think there's a comment by Simon Wheeler about interested in, again, I think the less common dementia types are being picked up when old age psychiatrists are not actively involved in assessment and diagnosis. And that would also possibly go for, functional illnesses sort of masquerading as dementia as well, which is why, we are kind of locally, we are kind of focusing on that sort of initial assessment and training. And it's a case of sort of skilling up everybody, including the psychiatrists, in terms of dealing with that sort of clinical complexity. And which is why I think it's important that we look at the redesigning of the whole services, because we do need to achieve efficiency where things can be done by the relatively less complex ones can be can be addressed by sort of other services, GPs including. Then it'll free up the capacity for us to look into the sort of more clinically challenging situations.
Thank you, Venkat. And again, there's a lot of points continue to be on PACS and scan access. That's really good that everybody thinks that's really important. And again, Vivek just now talked in about the sign guidelines, which is coming up as a pragmatic approach to this. The table Charlotte put about the NG97 is quite a useful thing of various neuroimaging techniques that can be used. And somebody put a question on how ready are we with regard to biomarkers, blood biomarkers. So incidentally, yesterday I was at a meeting where they were talking there's only 1% of the UK population have access to some of the biomarkers. So clearly, or some of the specialized amyloid scanning. So we are very far from the main, the mainstream. So, and Carol is saying you might get a boost from dementia diagnostic rate. Mike, and again, it's coding that is really important. This is what we think. Sometimes that's why we talk about accuracy of the data is important. Paul?
Thanks, Krish. There's one question right at the start of Q&A, which I don't think we've answered, from Mohammed Amin, which is a general adult psychiatrist, is very relevant, I think, which is when we as general adult psychiatrists refer people who are relatively young, say 40, who have cognitive decline, maybe some brain shrinkage on scan, maybe some temporal atrophy, but the main cause seems to be alcoholism. We certainly traditionally have found that tricky, and it's often been, should we say, rejected. I wonder what the panel's thoughts are about whether, is that the same across the country? Do some services welcome such referrals? I'd be interested to know about that.
That's really, thank you, Paul. Thank you for signposting. I think got scrolled down. So before I could answer, anybody in the panel want to talk about? Yeah.
I mean, it's interesting, isn't it? Because in my clinical experience, alcohol-induced cognitive impairment is definitely reversible, and I'm sort of remember a particular situation where one of our patients was sort of consuming significant amounts of alcohol, and they were so cognitively impaired that they couldn't manage any of their, including their basic activities of daily living. But we managed to achieve a degree of abstinence for a prolonged period of time. And these were the times when we were still using MMSE. So the score, the patient's MMSE score went from something like 5 to 25 in within sort of 9 to 10 months of abstinence. So there is that first point. And the second point, which I've just literally come off discussing with one of my colleagues managing an inpatient unit, again, a less than 65-year-old person admitted into one of her inpatient units with a long history of excess alcohol consumption. And it works the other way around as well. People with sort of very distressing mental health symptoms take to alcohol as a coping strategy. And when there is that sort of period of abstinence, the underlying mental health issues become more prominent. And my colleague was able to address a lot of those symptoms with the judicious use of antipsychotics. And this person is now almost ready for discharge. Both cognition and mental state have improved. So I think it's just remembering those sort of coloring factors as well. Yeah.
Thank you, Venkat. But coming back to your primary question, Paul, if there is a patient under 65 who has some cognitive impairment, I, as a clinician, I feel rejection is not a right way of collaborative working. I would like to look at like a joint visit. So I've worked with some of our adult colleagues and say, can I come with you to do an assessment? Shall we do a joint assessment? Shall we care coordinate for a few months to see where that patient is going to move towards? Seem to be a better collaborative way to support, because some of these patients can have functional problems, which our adult colleagues are much more experienced in that particular patient. Paul, do you have a reply?
That's music to my ears, Krish. I think that's absolutely the way forward. And it also upskills colleagues in general adult psychiatry who may not refer many such cases, so that we can learn kind of the things that you most find useful in referrals as well. I agree.
Absolutely. And it has been a win-win situation where we were able to signpost and then work together. And then currently, I think I have about 3 patients I'm working with our adult colleagues. And also the young onset, sometimes, again, nowadays we are seeing late 30s, patients developing, young onset dementia. So it is something, only thing we just be mindful, like, last week we had a 21-year-old develop, referred as a probable dementia, which is taking it a little bit far right now, I think. But apart from that, generally, we should work together on that. Any other questions anybody has spotted? Right, okay. I think probably it has been a really good discussion. We are probably only 10 minutes into, late into the 5 o'clock mark. Anything any of our panel members want to comment on? Thank you. It's been a really useful webinar. I don't know whether Subodh or Raoof, whether you want to.
No, I mean, I was just logged on to just say thank you. I think it's been an amazing session. And I think, well, I can see the chat response has been really electric. And I think it's a call for action now, I think, really. I think for me, I think that's the most important thing, that how do we really start narrowing the gap? I think we started with Pam's story, and clearly what we want is for that gap to be narrowed. I think her statement still rings in my head. That the sooner the diagnosis could have been made, the earlier the help would have been available.
Looks like there is another wish, Subodh, that because there's so much to do, they want another session. So I'm sure we can wangle one.
I'm sure that this will happen again. I mean, this is not going to stop, and so I'm sure that Raoof will be. I want to thank Raoof, and Deepa is not here today, but Raoof and Deepa are the coordinators of the Grand Rounds. So though it carries the name Dean's Grand Round, is very much as Dr. Raoof and Dr. Deepa Krishnan's Grand Rounds. So, and I also want to thank the staff, I think, who work so hard in the background. So Catherine, Charlie, and the team. So a big thank you to them, and a big thank you to all the people who registered and made the session so lively. I think that is really been very helpful. So thank you all very much, and great to see all of you again. Paul, Krish, Venkat, Charlotte, thank you so much.
Thank you to everyone. Thanks, Paul, and thanks to Catherine and Charlie and Calc team. So let's bring this event to a close. Thank you so much.
Thank you, everybody.
Thank you. Thank you, everyone. Thank you.
Thank you. Goodbye.
Bye. Bye.